How's it going, guys? We have a medium difficult question for Pharm Physio. Before we start, please subscribe to my channel. I really appreciate it. Give the like, really appreciate it. Find me on Instagram, Mehlmanmedical, Mehlmanmedical links down below. For me, Telegram, links to Telegram group channel down below. Let's start the clip. 52-year-old dude has hypertension. We're starting him on hydrochlorothiazide, and we're asking you something about the MOA of thiazides, what's going to happen. So I'm asking you watching this clip, where in the kidney are thiazides going to act? It's the DCT, right? So is it going to be the early DCT or the late DCT? It's the early DCT, okay? PTH acts in the late DCT. So the early DCT for thiazides, is it acting on the apical membrane side of the urine or the basolateral membrane side of the blood? It's the apical membrane side of the urine. And what's it inhibiting there? The sodium chloride symporter. So you say thiazides, they inhibit the apical early DCT sodium chloride symporter, fine. So by decreasing the reabsorption of sodium chloride across the apical membrane from the tubular lumen into the tubular cell, is it safe to say we're going to decrease intracellular sodium? We're decreasing sodium concentration within the tubular cell? That makes sense so far, right? Okay. So if we're decreasing intracellular sodium, we're going to be creating a favorable high to low gradient of sodium from the blood into the cell across the basolateral membrane. Okay, so far so good, fine. So what's going to happen is sodium is going to move down its concentration gradient from the blood across the basolateral membrane into the cell. And this is going to be a sodium-calcium antiporter on the basolateral membrane. So when sodium moves into the cell, calcium is going to move from the cell into the blood. We're reabsorbing calcium. So choice D is our correct answer here. This is how thiazides cause increased calcium in the serum, and they pull calcium out of the urine, causing hypocalciuria, which is why they can be used for recurrent calcium stones, okay? USMLE wants you to know the mechanism. So when you're pulling calcium from the cell, into the blood across using that sodium calcium antiporter on the apical membrane, you have a channel called TRPV5, which is going to have increased activity. Okay, so you got calcium going from the urine across the apical membrane via calcium channel, and then once it's in the cell, it's going to go via the antiporter, where sodium's going from the blood into the cell and calcium's going from the cell into the blood. So the 2 points, the 2 MOAs you have to know for thiazides, as we already talked about, number one, it inhibits an early DCT apical sodium chloride symporter. That's its main MOA for hypertensive effects, because when you're blocking the sodium reabsorption from the urine directly, you're going to cause natriuresis, fancy word that means micturition of sodium, and water is going to stay with sodium, and you can decrease your fluid status and blood pressure, right? But the other MOA on USMLE is just increases calcium reabsorption, okay? And you can remember loops do the opposite. So you say, well, if thiazides are going to decrease urinary calcium, increase serum calcium, loops do the opposite. So loops will cause increased urinary calcium, decreased serum calcium. Now, let's just whip through the answers here, as what we already discussed them. Choice A, decreased TRPV5 channel activity, is wrong because we just said it's going to be increased activity across the apical membrane, right, in order to increase calcium reabsorption. Choice B, decrease apical sodium calcium symport activity, is wrong because, first of all, we're going to have increased sodium calcium symport activity, and it's going to be on the basolateral membrane, not the apical membrane. Choice C, increased apical calcium antiport activity, is wrong because, as we already discussed, the sodium calcium antiporter is in the basolateral membrane, not the apical membrane. Choice D, increased basolateral calcium resorption. Correct answer. That's easy, even if you had no idea. I know some of you are like, well, I had no idea about all the fancy stuff you discussed, but choice D just makes sense because don't thiazides just pull calcium out of the urine in general? And that would also just, it would have to go into the blood across the basolateral also. So you could just infer that. It's not hard, right? But the answer choices are a little bit tricky nevertheless. And then choice C, increased basolateral sodium reabsorption, is wrong. So we said that sodium is going to go, it's going to be secreted. It's going to go from the blood across the basolateral membrane into the cell in exchange for calcium, which goes from the cell into the blood. Wrong fucking answer.